beyond the red. I'm living beyond the red. I'm living beyond the red. Yeah, yeah, I'm living beyond the red. Yeah, yeah, I'm living beyond the red. I'm living beyond the red. I'm living.
Good morning, good morning, good morning. Today, August 20th, is Southern HIV/AIDS Awareness Day. And we are so happy that you've joined us for this important day of celebration, of acknowledgement, of amplification, of sharing, as we work in the theme of power to the people. My name is Daphina Ward, and I have the honor of serving as Executive Director of Southern AIDS Coalition. And Southern AIDS Coalition established this Awareness Day. This is our sixth one, hard to believe, back in 2019, as a day to amplify the HIV crisis in the region, to amplify the necessity of policies, of practices, of resources that support those living with HIV in our region and support prevention strategies across our region. It's also a day for us to address misinformation, to make sure that we're spreading information that is accurate, that we are speaking truth to power in our communities, to end policies that are harmful, to end policies that are discriminatory. And it is a day where we celebrate that there are so many organizations, individuals, advocates, like so many of you, who are doing the work here in the South. You are empowering your communities. You are saving lives. You are doing the work in the face of great obstacles like stigma and misinformation. And we're just so glad to be here in this space with you. The theme Power to the People came to us because we realized that this is a critical year. So we are asking folks to lean in, and we are harnessing the power of our voices. We're harnessing the power of our history, the power of our joy, the power of our dollars, and the power of our vote. And that is all power that lies in the hands of the people here in the South and across this nation. This morning, we have the honor of partnering with our friends at Gilead. As you know, Southern AIDS Coalition is the coordinating center of the Gilead Compass Initiative. We have had the honor over the past several years to partner with other coordinating centers and implementation partners to support Gilead's effort of getting $100 million into Southern communities to address the Southern HIV epidemic. And so much of that has been leaning into and supporting the leadership of emerging leaders in the South, of small organizations who are doing mighty work and who are truly exemplifying what it means when we demonstrate that there is power, when we look to the people and we believe in the work that is happening in our communities. So we thank you so much for being with us for this first of many events over the next few days, where we will have critical conversations around HIV and intersecting issues in the South. So we're glad that you're here to join us. Thank you for those who registered to here in our webinar space. Thank you to our friends across social media who are with us. We hope that you will share this on your platforms, because we have a powerful conversation happening today with some wonderful leaders from across the region. Before we get to our panel and the workshop, would like to invite our friends from Gilead Sciences to come on, Patrick Lee and SHAAD Henry, who will be talking to us about HIV stigma and the necessity of addressing it here on SHAAD. Take it away, Patrick and SHAAD.
Thanks, Daphina. Waiting for my counterpart to come up on the screen, but as I will go ahead and start us off and introduce myself. I'm Patrick Lee. I'm the Executive Community Liaison with Gilead Sciences. I'm based out of Tennessee, one of our beautiful southern states, and we will be discussing stigma across the HIV care continuum and how we can fight it. Still waiting for Chad to come up, but I'm assuming that he can advance the slides. Our objectives today are to, one, understand what stigma is and taking a deeper dive into figuring out where it comes from, what are some of the related concepts, and how it impacts and affects individuals and communities that are impacted by HIV. Then we hope to explore some ways of implementing approaches to fighting stigma and to decreasing it in our communities and in our organizations, and then recognize the opportunities of how we can continue to combat it across the HIV care continuum. So stigma takes its place in many different forms. And when we think about what stigma is, we have to start with what we believe it to be. And it's negative attitudes or beliefs that people have toward distinguishing characteristics of others. So for example, Black people in history have experienced lots of stigma, and particularly here in the South, for no other reason than the color of their skin. And when we relate that to health concerns, HIV rises to the top. People are afraid of what they don't understand. So stigma is based in fear, and it's thought to be an actual disadvantage that a person has, which makes other people fearful of that disadvantage. So like I said, stigma can show itself in different ways. Sexual stigma, related to sexual behaviors, relationships, sexual minority communities. Homophobia, the stereotypes and the beliefs that people have about same-sex relationships. Transphobia, for folks that express themselves or whose gender identity or gender expression is different from what society says is normal or what society expects normal to be. And stigma can arise out of that. Then you have stigma that's related to people looking for access to medications to prevent HIV acquisition. And that is called PrEP stigma. And then we also have HIV stigma, which includes the negative attitudes and beliefs about people living with HIV. Now, we were warned very early on, because we're on such a tight time frame, to keep the anecdotes to a minimum. But I would be remiss if I didn't share an anecdote about stigma as it related to HIV, and just a case of a patient walking into a dental office and the dentist dressing up in complete garb, with a face mask, gloves, what looks to be a hazmat suit, just to talk to the patient, not to examine the patient, but to talk to the patient. And that's one of those instances where stigma can be damaging and harmful. So what causes stigma? Again, stigma is rooted in the imbalance of power, and it leads to labeling, stereotyping, and discrimination. And that's when a person knows that they are experiencing that stigma. And it can also lead to separation. It can make a person feel extremely isolated because of that. But the root cause of stigma is fear and lack of understanding. Now, I mentioned the fact that stigma can be very damaging, but one of the things that it does is it puts up barriers that weakens the ability of people to take care of their health and to stay healthy. It makes it harder for people to get, when we think about it from an HIV perspective, it makes it harder for people to get engaged in care and to receive medical care, to start and stay on medical treatment, which exacerbates the HIV concerns that we have in our communities. When we think about HIV continuing to grow, one of the reasons that it continues to grow is because it's growing in a pit of silence. It's growing from a place where people don't want to talk about it. We are over 40 years into this epidemic, but yet we still have some of the highest rates of HIV in the southern region. 52% of the HIV in the United States is found in the South. So stigma can take on many different forms. And we talk a lot about the external stigma, the energy that people put towards people who may be living with HIV. But we don't talk as much about the internal stigma, the stigma and the shame that people feel about themselves, that feeling that they're dirty, that feeling that they got this because they deserved it because of some type of behavior that they may have participated in. And that is the stigma that keeps people from engaging in the care continuum, and that keeps people fearful of sharing their status with others, because we think of HIV in the social aspect, as opposed to recognizing that HIV is a medical issue and we deal with medical issues medically. These stats from the CDC are somewhat alarming, but they are what we see in our everyday life. And I want you all to just think about that as I read through some of them. 4 out of 5 people being treated for HIV reported feeling internal HIV-related stigma. 2 out of 3 of the people in that study said that it was hard for them to tell others about their HIV diagnosis. 1 out of 3 people said that they felt guilty or ashamed of their HIV status. And 1 out of 4 said that being HIV positive made them feel dirty or worthless. I will tell you, having worked in this field for many, many years, there's not a dirty or worthless person that I have come across in all of the workings that I have done related to HIV. And the fact that people feel that way about themselves says something about what we are doing and what we're not doing as it relates to addressing this important issue. So how do we reduce that? One of the ways that we do that is by creating social support programs that can lessen the impact. We want people to think differently about HIV. So one of my mantras, and I've mentioned it already, is that HIV is a medical issue and we deal with medical issues medically. We deal with it the way that we deal with diabetes. We deal with it the way that we deal with cancer. And we have to get people in that mindset of believing that HIV is manageable, because guess what? It is. And we can manage it, but we have to reduce the amount of fear that exists around it. So what can you do? Within your organizations, you can routinely survey staff about HIV-related stigma to improve policies. You can continue to promote inclusivity and empowerment by using participatory methods of care, such as support groups and workshops. Use patient satisfaction surveys to assess how you all are doing. Ensure that all your staff is trained and understands the importance of patient confidentiality, and that we want to make sure that we maintain the privacy of a person's HIV status. And then use people first language. Instead of saying, you know, that person is, we have a person, that's an HIV positive person, say we have a person living with HIV, because we want to put the person first, put the issue behind the person, because at the end of the day, the person is the one that counts and the one that matters. So think of these questions as we get ready to transition over to SHAAD. But what are some of the main challenges addressing stigma institutionally? And what solutions would be most effective in addressing stigma within your organizations and among the people that you work with? Chad?
Thank you, Patrick. So this is an activity that you can do in your organization, really to sort of level set and think about where your blind spots might be in terms of policies and procedures and training. And so it sort of breaks out into 3 parts. So you really want to sit down and think about, what are my organizational potential blind spots around staff attitudes, provider attitudes. And I would say, think about everyone from the front desk to the billing person, right? You really have a clear understanding. You want to look at all your forms, whether that's an intake form, a sexual health assessment, or other materials that you're using in the physical environment during a visit. And then the physical environment, right? We want to think about what's on the walls, what materials people see in the waiting room. And, you know, those things really have an impact. What somebody sees when they're sitting and waiting, what they have access to when you're not in the room with them, can really shape somebody's visit. Well, as we think about policies, Patrick mentioned people first language, doing education like this, coming on webinars, utilizing the community liaisons in your area to talk about stigma at an organizational level, and then providing that support for staff to really be able to level set and have those discussions. And then certainly you want to gain support from all levels, right? So from the CEO and the board all the way down to everybody else. We want to make sure we're getting data and utilizing that the patient data that comes in through surveys, and then report out. So utilizing your community advisory board, talking about the things that you've done and the things that you implemented. So when we think about addressing stigma across the HIV care continuum, we always think about status neutral care. We know that HIV screening is the entry point into status neutral care, and how we sort of present what that path looks like for our patients can lead to stigma or alleviate some of the stigma. The more holistic we can make whole HIV screening in general, the more routine part of their care will tend to dispel some of the stigma that we are combating. So when we look specifically around HIV screening, we know that there's a lot of stigma around HIV screening. A lot of folks don't want to get screened for so many reasons, right? Fear of rejection, fear of judgment, of shame, fear of death, right? And we know we're in a place today where our medication, we don't have to die from living with HIV. We can thrive, but a lot of folks don't see that, and so we want to routinize our HIV screening as much as possible. So that could look like opt-out HIV screening. So if I'm coming into the clinic and I'm getting screened for diabetes, I'm getting screened for cholesterol, I'm also getting screened for viral screenings, right? And so how we have that discussion will determine whether or not somebody may be like, oh no, I don't want to do that. One of the best practices that I learned when working on opt-out models was really, hey, we're going to be doing some viral screening today. That's going to include HIV, hepatitis C, hepatitis A and B. This is a routine part of care, and leave it at that. And then the patient needs to literally opt out. Most people will, when you're given them an option, say, hey, would you like to be screened for HIV? A lot of folks will say no because they don't recognize or realize what their risk is. So as we think about some of these best practices, I'd pose these questions to you. How might magazines or pamphlets related to HIV awareness mitigate stigma? And determining which ones people have access to can play a big part in that. And what are some other tips you can utilize to mitigate stigma in HIV screening? So when we think about PrEP, we know there's a lot of sexual stigma already, and you add in PrEP, there's stereotypes that people have around who they think the PrEP user might be, meaning they might make assumptions around the number of sexual partners you have. They might make assumptions around the types of sex you're having when you're utilizing PrEP. The more we can, again, level set that PrEP is a tool that folks can use to empower themselves to take care of their holistic health, it's always going to be better. So reframing how taking PrEP medication is something that doesn't have to be negative, right? It doesn't need to be tied to negative connotations. It doesn't need to be tied to promiscuity. I don't really like that word because I think that adds other levels of stigma. The other thing we want to talk to folks about is how do they have conversations around their PrEP use for folks who might ask. So you may want to consider these questions here on the right side. What information about PrEP medications would alleviate concerns about someone's sexual activity if they're asked about it? And also, I think thinking about that internal stigma, that adjustment is going to be important when we talk about PrEP. So let's talk about condom use, right? There's a lot of stigma around condom use, and I would bet if you were to poll people and ask them the number one reason they don't want to use condoms, they're probably going to tell you it has to do with how it feels, right? Or it's less intimate. And that may be true for some folks. The reality is condom use has shifted. I know in the 90s, when I was a little younger, condom use was talked about a lot. And we were in sort of a different perception of time then around protection. And now we have a lot of folks using less condoms, even though we have more options for condoms, right? So a couple things you can do really is make condoms, both insertive and receptive partner condoms, available not only in spaces where you're interacting with the patient, but have them available for the patient to take when you're not interacting with them, when you're not around. So in the waiting room, in the clinic room, in the bathroom, in a lot of different places, so people can access those. The other thing that's important as we talk about condom distribution, we want to supplement that with other risk reduction interventions. So we want to be talking about routine screening for STIs and HIV. We want to incorporate this in some of our promotional activities that we're doing. So some questions you might think about as you think about condom distribution: what policies do you currently have? Are there areas where you can make adjustments around how you're providing education? Are there things that you can do that will help mitigate some of the stigma around utilizing condoms? And then how do we address the misperception that condom use impairs intimacy between partners? Okay, so when we think about PEP, post-exposure prophylaxis is one of the most underutilized tools that we have out there, and it's been around longer than PrEP. But some examples of stigma related to PEP might be somebody who utilizes PEP or goes into a clinic to get PEP maybe has made poor or riskier decisions around sex. Certainly coming from a place of sex positivity, we want to be careful how we term some of these things. PEP also might be confused for somebody living with HIV because it is an actual medications that can treat HIV. It may be related to relational mistrust, and it may promote multiple sex partners. I tend to think that PEP is, the situation where I maybe met up with somebody and in the spur of the moment, something happened. We didn't use protection. Maybe somebody wasn't on PrEP or we didn't know their status. But it's really a tool to empower me taking care of my own sexual health. So some of the ways we can really look to address or some best practices would be to streamline PEP services. And what I would say by that is make it as seamless as possible. We don't need to collect 5 pages of risk data for somebody who's coming in. If they're coming in and they're specifically asking for PEP, they know what their exposure is, so we should provide access for them. We want to frame PEP to minimize perception that it's about mistrust between partners, or that it means we've had multiple sexual partners. And I also think how we educate, right? Again, we want to, when we educate about prevention, whether that's PrEP, whether that's STI screening or PEP, we want to normalize those conversations across the board. So a question to think about as you consider PEP, how do we mitigate the stigma of PEP being associated with HIV without increasing HIV-related stigma?
And Chad, really quickly, it's a wonderful way for us to bridge that conversation between PEP and PrEP as well. In the instance that old adage, an ounce of prevention is worth a pound of cure. If a person comes in for PEP, maybe not asking all those 5 pages of questions, but then having a discussion about how PrEP might be a wonderful option and opportunity for them to further protect themselves.
Absolutely. Thanks for adding that, Patrick. And I also think it's an important transition. If somebody comes in for PEP, we should automatically have that built into our process to get them connected with PrEP immediately following their PEP medication. So when we think about treatment or antiretroviral treatment, there's a lot of stigma, and often, the thing I hear stigma about is the bottle. And one of the things that I have heard many folks say, and people tell me, is that they will tear the labels completely off the bottle so that if somebody were to find the bottle, they don't have an inkling about what's inside. That people will also share that they get nervous taking medication in front of other folks. And often they internalize some of that stigma, and it may lead to depression, or may just lead to them deciding not to take medication because they'd rather not be seen or have it be found. So some of the best practices we can do really build awareness around sort of mental health and depression and how that sort of plays a role, right? We know mental health is a really powerful thing. And for me, that internalized voice in my head is really powerful too. And so if those things are telling me things that are negative, or I'm judging myself, or I'm in a place of shame, taking my medication might not be top of mind. But we really need to, as we think about working with folks and talking to them about the importance of taking medication, we also want to make sure that holistically everything else is going okay as well. And mental health should be at the top of that. We also understand and address what avoidant coping is, and know that it can negatively affect our adherence, right? And what I mean by that is to avoid dealing with this situation, I'm just not going to deal with it. So I'm just going to pretend like I don't have it. I'm not going to take this medication, right? We want to make sure that when we are working in community that we're having conversations. And I think this is really, this is something that comes up a lot when I do support groups and we talk about this. We talk about this stigma of taking medication. So something to consider is how might the practices outlined here help you mitigate stigma? Are there other ways that you all currently work towards alleviating some of the stigma related to medication? And what are, think about what some of those options are. Okay, so helping address stigma related to treatment as prevention. The information on the screen comes from 2018 forward, and we know that education continues to advance, and we know that treatment as prevention, or sometimes termed as undetectable equals untransmittable, is becoming more widely known. However, I would bet that many, many people still do not know, especially outside of gay and bisexual men, don't understand or know what undetectable equals untransmittable is. Now we know if you're undetectable for at least 6 months, your viral load is below 200, and often labs go way below that, but are below 200, we can't transmit to somebody sexually. So I think that's really powerful information, but I also think it's really important that we pay attention about how we have this conversation with folks, how we educate, because there are going to be some people who are not going to get to undetectable. And for those folks, we don't want to add another layer of stigma that they might already be dealing with. We don't want to make it harder for them to deal with that. And we do know that even we have this messaging, you're seeing billboards pop up, you're seeing CDC and many, many, many other people talk about U equals U on a regular. You probably heard, if you've talked to any of us, the community liaisons, you hear us talk about this all the time. But even with all that education, many folks still don't believe that undetectable truly equals untransmittable. And the other thing I might add is undetectable equals untransmittable is really around HIV. We still need to be thinking about all the other STIs, right? Chlamydia, gonorrhea, syphilis, herpes, all those other things that will still be transmitted if we have those, or we can still acquire. But when we think about best practices, we want to encourage wide acceptance of treatment as prevention, or U equals U. We want to continue educating folks. And when I say educate, I think regardless of what somebody's HIV status is, if someone's coming in for HIV STI screening, it's a prime opportunity to have that conversation around PrEP, around treatment as prevention. We know those two tools together, PrEP and treatment as prevention, are the keys to ending the epidemic, right? So the more we can level set, we can make this part of our conversation anytime we're talking about sexual health, the better. We want to continue to develop educational campaigns through apps and social media, and you want to make sure that those things are inclusive to everybody. We want to focus messaging on individual and population levels that's relevant to age, culture, and educational levels, right? We want to meet people where they are, and we want to deliver this information in a way that resonates with them. So switching gears just a little bit, right? We were talking about how we think about stigma across the HIV care continuum, and really, how we normalize HIV stigma, how we normalize HIV screening, HIV care, PrEP, PEP, all of those things. Now we're going to talk just briefly about fighting stigma in your community. And so when we think about fighting stigma in the community, I think it includes all the things we've talked about and more, right? When we think about who to engage, often folks have a community of people that they work with, whether that's faith leaders in churches, whether that's a community center, whether that's engaging with certain folks from their community who are leaders who they trust, right? We need to engage all of those people so that they can pass on this information and education and dispel some of that stigma. Because I always talk about this. I could use myself as an example, and I can come in and educate folks, but I'm not always going to resonate with everybody, right? I'm a white gay man living with HIV, but I'm also not going to appeal to everybody. And so I think it's important that we empower people from your individual community to provide that education, because it's going to resonate in a way that's very different than if you're only hearing from, say, me or Patrick. We want to include HIV screening education. We want to talk about full spectrum prevention. We want to talk also about holistic health, right? I think we're doing a disservice if we don't talk about holistic health. We need to be talking about my A1C, my cholesterol, my HIV and STI screening, my status, if I'm taking my medications for everything. That, the more we can make this a routine part of a holistic healthcare, the more we take away some of that stigma related to HIV. So how do we develop? It's important to get input from sort of all levels, right? Whether that's from our government agencies like health departments, local advocates, community advisory boards, or members of the community, right? I think for me, the most powerful messaging we can get is from people who are living in community, right? People understand themselves, they understand their community, and they can provide that feedback. We want to ensure that we create a space where people can provide transparent feedback, and we want to collect that information and actually utilize it in the work that we're doing. So we don't want to, do a needs assessment, collect a bunch of information, and then that's sort of where it ends. We want to take that information and compile it into action and then put that out there. So some other questions to think about. Besides HIV screening, what other kinds of health and wellness messages might work best in your community? How can we evaluate whether efforts to improve HIV stigma in the community are working? So where can we intervene to mitigate the spread of stigma, right? We've talked a lot about different access points. We've gone through all the different types of stigma, and we know that when stigma or thoughts related to stigma or negative thoughts or connotations become action, they could become discrimination, right? And that might lead to lack of access. And we're here in the South, we have a lot of rural areas. We don't always have a lot of opportunities or options on where we can get our care. And if the place we're getting access to our care, we go in and we don't feel safe to be able to talk about what we're really dealing with or who we are, or we feel discriminated against, that might be the cutoff point, right? It might separate us from care. It's also important that we think about how are we educating? And I don't mean just educating in the health centers and the health departments and the communities where we might get access to HIV screening or HIV care. How are we going to educate everybody, right? How do we take a personal approach in educating? I think that that's really important. And so in order to do that, we have to have access to the information ourselves, and then we need to be able to put that out there. And when we think about advocacy, we have all sorts of policies and governmental laws and regulations, like even HIV criminalization, right? We still have many places where you can go to jail if you don't disclose your status. We need to advocate to change those things, to change some of that power imbalance, and questions to really think about: how can we advocate for the elimination of laws and practices that facilitate stigma? And I think this goes in a wide variety of things. It isn't just related to HIV criminalization, right? There's a lot of things we need to think about and advocate for. So in summary, we talked about a lot of things. We went through internal and external stigma. We talked about organizational stigma. We're talking about how do we address it at a community level, right? This was really a high level presentation. Really, we went through it pretty quickly. And we as community liaisons have a number of resources related to stigma, and we'd love to be able to talk with you more about that. You can find additional resources here at gileadhiv.com. Or by scanning that QR code. And as you can see, we have a number of presentations and discussions that we can facilitate, as well as some other things listed under other resources. And we are really grateful to be here, and thank you for giving us the opportunity to talk with you briefly about stigma this morning. And we will go ahead and turn it back over to Davina.
Thank you so much, Patrick and Chad, for that great information. I want to encourage folks who are in the chat, if you have questions, let's please address those. I want to lift up something that Kenny Talbot put in the chat. I have to say, this doesn't really address stigma. The way to address is to understand self-stigma on a personal level. Remember, we all don't think the same way. Let people speak and listen to what they have to say. Be an ear and not a mouth. Thank you so much for that, Kenny, because it is so important that we think about individualized stigma and the fact that we all bring our own experiences. People bring their own judgments, and that's really important for us to lift that up. And that stigma is very layered. People talk about stigma as being an onion, right? There's so many layers to it. Really appreciated the conversation. In looking at the whole idea of the imbalance of power, and how that really does kind of set as a foundation for the way that stigma impacts so many people in our communities. So we're going to try a thing. I want to invite Christopher Lane to join me here on screen and see if Chris can hear me this morning. Chris, can you hear me? So we were going to see if Chris and I could jump on here together, but you all know how technology goes. So Chris may not be able to hear me, so we will keep it moving. Now there's two of them. All right. I don't think Chris can hear us this morning.
I can hear you.
Oh, it's a miracle.
Can you hear me? I don't know what's happening, but it won't.
So glad you can hear me. So Christopher Lane is currently a community liaison with Gilead, covering both Mississippi and Alabama, and is new to this position. Prior to this position, he was a research compliance specialist at his alma mater of Jackson State University, HBCUs, and has over 20 years of experience in HIV, 25 years in public health. And I have to say that prior to returning home to Mississippi in 2014 to assist with his mother's care and eventually become a full-time caretaker for her. Bless you, Chris, for that. We talk about all these layers of things, right? And these intersections of real life experiences. Christopher held a position with DC Department of Health, HIV/AIDS Administration. Christopher just has a lot of great credentials in this work on so many levels. He's a 2006 fellow in the CDC Institute for HIV Prevention Leadership, has worked closely with the Mississippi Department of Health to help reverse the path of HIV that's adversely impacting Mississippians. And we just know that you are an advocate in this work, and we're so appreciative for you guiding our conversation with our community leaders today. So I'm going to say, welcome, Chris, and you can take it from here.
Thank you. Thank you, Davina. Thank you so much. You two are an advocate in your very own right, and you are so appreciated for the work that you're also doing in the South. We're glad you're here. So I'll just jump right in. So we'll be having our panelists today. We'll have Miss Mia Cotton, and she is an employee at Friends for All in Memphis, Tennessee. She's the Chief Program Officer there, where she has spent a majority of her professional career in HIV, and has had a front row seat to this evolution since 2010. Under her current leadership, Friends for All, she provides a comprehensive array of programming inclusive of status-neutral services, HIV prevention, and treatment that consists of programming to address the social determinants of health. So her passion are aligned to be hope, help, and healing for communities that need it most, especially those living with and affected by HIV. Thank you, Mia. And next, we have Javar Payne. Javar is the Executive Director of CARP. So that's Capital Area Reentry Program. He often says, I do it for the movement and not for the money, which has elevated his career and community involvement. As the Executive Director, Javar, and at CARP in Baton Rouge, Louisiana, his team is dedicated to changing the narrative of reentry amongst health, wellness, and economic justice. From syringe access to HIV prevention and treatment, screening, and linkage, CART provides services to all members of the Baton Rouge community and as well as returning citizens. He's also the chairman of the Baton Rouge Ryan White Advisory Council, member of the Louisiana Tobacco Free Living Advisory Council, and he is also the Baton Rouge Wellness Center Advisory Council co-chair. So let's welcome Javar Payne. And last but certainly not least, we have Miss Janet Kitchen. Janet Kitchen is the founder and executive director of Positively You, Inc., whose mission is to provide culturally appropriate and compassionate programming to HIV positive and HIV possible individuals in Tampa, Jacksonville, Orlando, Gainesville, Winter Haven, Florida. So she currently serves on many state and national advisory boards advocating for the rights of people living with HIV. She's developed and implemented peer education programs, micro-enterprise workshops, and motivational seminars for people living with HIV throughout the state of Florida. She's a lead regional mobilizer for the state of Florida, where in July 2012, she was instrumental in mobilizing over 400 Floridian advocates and people living with HIV to participate in one of the largest gatherings for people living with HIV, the March on Washington at 2012, at the International Conference on AIDS in 2020. Let's welcome Ms. Janet Kitchen. So thank you so much for joining us this morning on really critical day as we think about how HIV impacts those of us who live in the South. So I want to start with you, Leah. I want you to share a personal story. We had some great conversations on yesterday, and you all highlighted some really great things. But I want you to share a personal story of your experience as it highlights the challenges and triumphs of living with or fighting against HIV/AIDS in the South. How has that been?
So I will say it's been very busy. The last couple of years have been very busy for us. I'm sorry, am I frozen on your side? Because I look like I'm frozen over here.
You're a little frozen.
Oh, it's
but
a horrible.
I think if you keep moving, you may come back.
Okay. Gosh, that's horrible, and it's recorded.
But we can hear you.
Okay. All right. So essentially, we've been busy for the last few years. As many of you know, we had a big situation happen when our state government gave back CDC funding for prevention activities. With advocacy in your voices, we were heard, and fortunately, the state has funded us at full capacity plus the CDC. So that's been a big thing. Earlier this year in Tennessee, we've had some success with some repeal of criminal prostitution laws. And then we are still, unfortunately, dealing with some anti-drag laws and some discriminatory laws against individuals who are seeking gender confirmation surgery as a youth, or treatment or services. Also, we are now number 2 for HIV infections currently in the country. And we have just had a law that was passed that prohibits our ability to test minors without parental consent. So we've got a lot of things going on. One of the bigger parts for us around stigma was our building and our space. We've been around since 1985, and our space that we were just recently in was so stigmatized that I had people who would rather stay on the street than come indoors and get care because they knew the type of work we did. We had 2 apartment buildings that individuals would rather sleep outside than live in those apartment buildings because of the stigma, because they knew everyone who lived there was living with HIV and AIDS. So for us, it was really important to rebrand to try to figure this out so that we could make sure people could receive services with dignity. So we went on a campaign to be able to open our new headquarters. We opened our new headquarters in 2010 with a rebranding. We have been friends for life since 1985, and we will always be your friend for life. But our rebrand is Friends for All, because we want to make sure we're here to take care of everybody. And that's our nod to inclusivity around stigma in the South. So our space, no matter whether you're a CEO or you are sleeping under the bridge, you walk into a space that is dignified, that is beautiful, and that anyone could receive care. We have gender neutral bathrooms throughout our building. So you do not have to stop and think about, wait, which one do I need to go in? That's not an issue. Everything we do around here, and our nod here in Memphis has been a nod to dignity and giving people the respect they deserve to get the services. We wrap everything around. Memphis is horrible with transportation. You cannot get anywhere. So we really wanted to focus on, if we can get you here, we can get all of these services, from mental health, medical nutrition therapy. We have a mobile unit that can go out to do prep and PEP. We do rapid start. We have early intervention services. We have medical case management. We also help pay for copays and deductibles for not only people who are living with HIV, but people who are on PrEP, because PrEP is just one part of it. People need primary care. People need access to all care. And I want to remind folks, Tennessee is one of those places that did not expand Medicaid. So that just makes all of these things even more complicated. So when you talk about our nod to stigma, we are living in it. It is a barrier that we deal with every day. But the way we have tried to focus on this is through as much advocacy as we can do, and making sure the people that we can access can receive services with dignity, feel safe, and have access to the things they need. And so
thank you, Mia. You said a whole lot. I think that a lot of us who live here, who work here, can also relate to. So Javar, give us some more of that, what's happening in Baton Rouge as it relates to some of the things, that the challenges, and also the highlights that you all have experienced as well.
Yeah, thank you. Excuse me, my allergies are attacking me. But in Baton Rouge, capital area entry program, we are dedicated to putting peers on the ground, putting peers first. People with lived experience come with a unique perspective, dealing with a lot of stigma, a lot of trauma, is pretty much really, really high. We serve the underdogs in the community. Capital area reentry program, we do a lot. We are a small but mighty team. We have our Be Safe, our harm reduction syringe service program. We do prevention, linkage to care. We have Out of the Box LGBT Center. We do reentry services for formerly incarcerated individuals. We do research projects. We have a houseless, unhoused, gaining support program, our HUGS program. And so, we're just centered in holistic harm reduction and prevention opportunities for folks, because we have to realize that we are human beings. We love, we live, and we want a space that we can do that without being stigmatized, without being bashed, without any ill towards us. All we want to do is live. And so throughout all of our organization, we just want to provide compassionate engagement. And especially with harm reduction, it's really rampant. And so for people that are using drugs, people that are injecting drugs, to have a place where they can come and get resources, that we don't stigmatize, that we just are a friend. We want to be there when no one else is there for them. Now I can talk all day. So
thank you, Javar. I love that. Thank you for that. I think you all are raising some very important issues. I think that the linkages are, links that connects to what all of us have seen and have experienced in the South. So Janet, jump right in and tell us some of those challenges and highlights that you're experiencing there in Florida.
Florida. We're always on the map. We used to be high in cases and incident rates, but now we're just in the news. Florida is the most southern part of the state, but the most backwards thinking, aka our governor. We now call him the Satan. So I digress. Because of the political climate here in Florida, we have a lot of challenges. Positive U is one of those small, quiet giants, I would say. When I decided to found Positively You, I wanted to be something out of the box, something that no one would really know what we're doing. So Positively You could be HIV positive. Positively You could need food. Positively You, on and on. So it doesn't really hone into really HIV until you come in and then you see the whole wraparound service. But one of the things that I wanted to do is, in particularly stigma, was to find a way to change that tone. So we created an out-of-the-box theory. We have our own little language in Positively You. If someone comes in, they're HIV positive, they're called a star. If someone comes in and they're a woman that need care, we call her a shining star. And then we go on and on. But then we have VIPs, and those are people that are seeking PrEP and having PrEP services. So at any time that we're speaking among ourselves in Positively, no one will never know, and we're not stigmatized. When I say, oh, I have a star here, everyone wants to be a star. It makes them feel good. But some of the other things that I honed in services that I wanted to do was to make sure, like Javari said, those of us with lived experience to actually use those lived experience, not only use them as the front desk person, but use their really life experiences. They're not just the receptionists, they're our program managers, they're our case managers. No major decision in Positively You is made without my comrades, my peers are involved, because we are Positively You. So trauma informed, we're working on that now. We're revamping the whole organization. Time changes, language is changing. So all of our locations, we're doing that and making sure that gets done. And just quickly going through our services that we don't think about. We have transportation for primary care. We provide food, and not only food, we provide fresh nutritional food, case management, and co-payment assistance. Those are just some of the things that we do, that we know that when someone comes in, it's not necessarily talking just about HIV.
Thank you, Janet, for that. So one of the things that I think that one of the topics that you all have continuously expressed during this, during your talks, is around policy and advocacy. And also even in your intros or your bios, a lot of that was also highlighted as well as far as advocacy goes. So talk a little bit about how has policy influenced or not the work that you all are currently trying to do where you are. Anyone can jump in. Javar, you're muted. Javar, you're muted.
All right, so I guess I can jump in there. I'm sorry, I was pressing mute and then okay. So 4 years ago, I was able to take over the organization as executive director. I was hired in 2010 to be the first peer patient and health navigator, and I worked with over a decade in that position, and to be able to elevate from a peer with lived experience, helping other peers, to now leading an organization. I wanted to be intentional about our policy. So I threw every policy out on the floor and I said, out of here, because I have to realize that our policies are creating barriers for people to receive care, to access care, to retain in the care. And so my policies now are very general because I want it to be holistic, people-based. And so everybody comes in with a unique perspective, with a unique need, and those needs need to be addressed in that format, you know? And so by eliminating a lot of those policies, we saw a lot more engagement with folks that transcend different barriers, you know? And so I believe that we all have to look at, as our organizations grow, what our policies are doing to those that we are serving. And so we have to be intentional about policies and not overdo it, because you're hurting the folks that you're bringing in, you know? So that's my view on policies. We really have to really be intentional about what it is doing to the folks that don't know how to navigate their own healthcare.
And Jabbar, speak a little bit about how does just legislation and policy outside of your organization influence the work that you do as well? Because I know that I know Mia talked about earlier about some of the things that they dealt with in Tennessee, and then Janet kind of highlighted a lot of the pieces that, you know, things that have been going on in Florida, just overall. How does that influence the work you've done? Because I know that Louisiana did expand Medicaid, but I also know that you all got different leadership, and that may be in jeopardy. Can you speak a little bit about that?
Yeah, you know, we deal with so many different areas of policy, especially with harm reduction. With harm reduction, you know, having a syringe service program and getting those safety works out for folks, you can't do it in certain jurisdictions in Louisiana. You know, thank God that Baton Rouge, you know, passed their legislation. But some of the places and some of the parishes that we serve in our region, we cannot really access to or provide those kind of services to, because that jurisdiction does not have that available. And so it prevents people from getting care, from preventing them from getting the resources that they may need to live a healthy life, you know. And especially with HIV, with Medicaid expansion, it was great because a lot of folks that could not afford insurance was given a platform in which they can now advocate for their health care without running up the hospital bills, without trying to avoid the hospital, just so that they wouldn't receive a bill. And with our LAHAP, the Louisiana Assistance Program, it allows us to cover insurance premiums and different things like that. So it takes that second guessing or that barrier of entry to healthcare away, and it gives power to the people.
Yeah, absolutely. Thank you for that, Jabbar. Mia, can you talk a little bit about what's happening in your state? Because you raised it first, so I want to go back to you about some of the things that you have dealt with as it relates to policy and advocacy in Tennessee.
Yes, that has been my life, actually, for at least the last couple of years. We've had a lot of legislation that has been problematic. So for us, one of the things when it comes to policy, like I said, the most newest barrier right now we have is this law that at this point, we cannot do testing to minors, preventative screening, such as HIV and STIs, under the age of 18 without parental consent. Now, if we look at our statistics, I got to talk to my mama or my daddy or my parent before I tell you all these things that I've been doing. And now they're going to know. So you think about the challenge that creates for us as an entity, where we could previously test as young as 14 without consent. The consent came on the treat side. So we're kind of between a rock and a hard place there. And honestly, this just happened July 1. So we really don't know what we're going to do to work with this law. We haven't had time to really gather ourselves yet. This just happened last month. On top of that, we're second for new HIV infections. And so all of these things just lead to barriers. You add issues of transportation and access to services. We are just getting ourselves back together from the pandemic. And we in Tennessee, and most of us in Tennessee, had to have a halt in our prevention services last year as we were navigating the situation with the state and the CDC funding. One of the things for us that we find to be a challenge, even when it comes down to access to insurance and services around policy, because it's, again, Tennessee did not expand Medicaid. Even for individuals that do have insurance, our unrestricted dollars, or the dollars we have to provide these services for free, are running low. We do have people who come to see us who are insured and are fearful to give us their insurance information because they don't want this information on their EOBs or loved ones or other people to know you went to this place. Why are you going there? To question the care that they're getting. That's still a big barrier for us as we're getting into how we're going to cover these services, because we're finding out more and more. And honestly, there's nothing we can do about it. Like, we can call certain entities or certain insurance companies and ask that an EOB be not sent, but it's the luck of the draw whether that actually happens or not. They still may send it even if you request it not to. So that's a barrier we're dealing with also. And then in general, when you just have anti-drag bills, people can't express themselves without fear of being arrested for expressing yourself. We have youth who cannot access gender confirmation services. I get really upset when I think about, I had a staff member, she just left Tennessee. She was phenomenal. She was our head of HR. She had to go back to Chicago because of the laws in Tennessee and her family. She could not stay here. So we are losing good people to the South for some of this legislation because people just can't survive and do these things. So for us, it's constant. Again, our big battle now is dealing with an uprise in infection, an increase in infections, and how are we going to access that group when we can't necessarily test them without their parental consent? So those are all the things. We also keep a consumer advisory board, and we have our board has people with lived experience on our board of directors. So we make sure we try to get all that communication happening so that if there is a policy that doesn't work, that we can really look at it and it goes in front of an interdisciplinary team. And when I say interdisciplinary, staff, people who are receiving services, whether they're positive or negative, we get a group to kind of look in to see if these protocols are actually working in the way they need to. So that's our summary.
Thank you, Mia. So you and Jabbar have both said a lot. I want to hear from Janet about your experiences in Florida. I think some of those things have been highlighted. I would say more so than others. So tell us, Janet, what are those things that is happening in Florida for you?
So, yeah, with Florida, I know we have hundreds and hundreds of anti-LGBT laws. So much that a lot of the queer families are afraid. A lot of our trans women are afraid because of the violence that's being happening. Even coming to care, we have to make sure that we're protecting our community. So the inability to expand Medicaid is horrendous. It's really, really difficult. And I agree with Mia with unrestricted funds. It's very difficult to stretch those dollars. I mean, where do you get unrestricted funds from? Most grants are very, very stringent on what they do. And I will tell you that HIV for me is not, it's in my blood, I can say. It's not just for this here moment. It's a movement. And there was a grant that I actually turned away. And it was thousands of dollars because in the grant had its own stigmatized questions. We had to tell how many people were in the household. We had to get monthly bank account statements, all for an individual to get a bag of food. And in my mind, I could not do it, and neither could the other executives. So we gave the money back. We're struggling, but to me, it was the right thing to do. It was the right thing to do because these are policies and laws that, again, stay in our bedrooms and stigmatize us because of a diagnosis. And I just could not have it done. So you all, if you don't have anyone that knows how to give unrestricted fund, positively use waiting because we need people. Food is high. The cost of living is high. And we know that disability is at a flat rate. So those are some of the policies that really jump out. The other is that we don't have transportation in the South, like other metropolitan areas. A lot of our money is used for bus passes, which is good, but we're getting ready to go back into the high flu and cold season. So do we really want to put our folks on these buses and well, we don't have train. So transportation also is another issue, to be able to get transportation to folks for just to be able to get the needed services that's out there. We, of course, we have book banding. So the whole idea to even educate, we develop our own pamphlets, but we have book banding in this state, which I used to hear about that in just history and just knowing policies like that. And as far as this, the governor with his thinking, the idea of sports, people are trans experienced in schools, not allowing teachers to put their partners, loved ones or spouse on their desk. And if you, in this state, do not call someone by their assigned sex, you can be fired. There's just a lot going on too here in the state of Florida.
Thank you all so much for that. And I oftentimes I think we don't always speak about the resiliency that we often have to do, have to be, have to show up, even in the midst of all of those negative things that we have to do this work in. And I can say that because I live here in Mississippi. I also cover Mississippi and Alabama. So I've seen what those things can do and how that impacts people. Thank you all so much for what you shared today. And thank you for what you're doing. And we elevate you to the highest level and give you the most encouragement, even to your stars. Janet, I love that nomenclature for those persons. And I think the work continues as we continue to do this work in the South. And thank you all again for your work. Thank you for coming on today. And I wish you all the very best as we continue to do this work in the South to get closer to ending the epidemic. And so now, at this time, if there are any questions, you can feel free to put those in the chat. And of course, what I would love to see also is that if those of you who are in the chat would love to see something like this moving forward, please let us know that. And also, you can just, I think, I was going to ask you to drop and let us know where you all are. But I think you all have done a great job at that, and we appreciate that. So now, if you have any questions, please drop them in the chat, and I will relinquish my stand and bring on my coworker, Mr. Mac John. Thank you.
Thank you so much, Chris. We'll now have Carolina come on to provide remarks. And thanks so much to our wonderful panelists.
Hello, good afternoon, everyone. Can you hear me okay? Okay, awesome. Thank you all so much. Thank you for our panelists. Thank you for everyone showing up today. I briefly wanted to just speak with folks and wrap this up, So for a while, the South has been the epicenter of the epidemic, and this National Southern HIV/AIDS Awareness Day is our time to bring back power to the people. And we had 52% of the new HIV incidents occurring in the South, but we represent only 38% of PrEP utilization in all of the United States. It's time that we increase our PrEP uptake, okay? So according to the AIDS View, there are 10.5 PrEP users for every new HIV diagnosis, and that's compared to 22% of every one new diagnosis in the Northeast. And we have the community liaisons here on the call to help agencies with this effort. And for much too long, the best practices, we hear them coming from the Northeast, from the West. It's time for the South to disrupt this trend and really take the lead here. We have such an important opportunity. We need to increase testing. And this is something that I love saying, and it's an important call to action. No matter the results of the HIV test, every single HIV test should result in an action, right? We have the opportunity to lead in advocacy, lead in social political efforts to improve policy, and ultimately lead in our fight to end the HIV epidemic. So I want to ask folks in the room, right? You just heard some amazing stories of resilience, overcoming, and personal efforts. And as people on the call who represent different agencies, different organizations, please let us know in the chat what you will commit to doing to end the HIV epidemic in the South, and what role will you play? And please also let us know what agency you're representing as you type that in the chat. And one quick note, I know someone asked about slides earlier. So we're not able to share that, but please connect with your community liaison because they will be able to bring the presentation to your agency. Right? So I'm looking forward to seeing those comments in the chat.
Carolina, I think folks are thinking about what you challenged today. So thank you so much. There is a link to a survey there in the chat as well, and we'll also share it with all of our registered participants because we do want to know how you're using your power. We do want to know how we can bring additional programming to you and how we can be supportive. So I'm going to share a couple. We've gotten some thoughts. We're going to fight gender and sexual orientation norms of those living with HIV and eligibility for PrEP, advocate and speak out about stigmatizing marketing, and create safe spaces with a status neutral approach. And that is in New Orleans. Thank you so much, Jake, for that. Jacob with Pride Health, thank you for responding. Working to bring knowledge and advocacy for persons to better use their health insurance to maximize their care and make their care work for them, including finding assistance programs and speaking with healthcare providers and insurance carriers along with the client. Now that's advocacy. Thank you so much, Jacob. Stuart wants to continue to work through federal grants and other means on building capacity and supporting efforts in southern states with respect to integrated HIV planning, access to health insurance, expanding telehealth, especially in rural areas, and streamlining eligibility requirements. Thank you so much. Let's lead with love and intention. Thank you, Angelita. Yes, HIV prevention to Black women, girls, including trans women, stopping stigma with education, headquartered in DC, the Association of Black Social Workers. And I know that there's a lot of great stuff showing up in the chat. We may not get to read them all, but this is wonderful. Howdy, Oscar. We are so glad that you are here to support the folks across Texas. Robin Webb, a powerful advocate in Mississippi and SAC board member, dedicated to organizing people living with HIV-led networks across the rural South, starting where you are, Robin, in Mississippi, for the purpose of driving our own policy and quality of life narratives. Absolutely. Kara in New Orleans, working with trans women, trying to increase the uptake of PrEP. Absolutely. All right, increasing intentional partnerships to join you all in outreach. I don't want to pronounce it wrong, Jamie. Coker Gordon out of Maryland, thank you so much. So many responses around actions folks are taking, not just in the communities, but also talking about what it means to talk to folks who make decisions in insurance companies, medical providers. So we recognize that our advocacy has to be across the board. Carolina, is there anything else you want to say? We have so many great responses coming in.
Yeah, this is great. Thank you so much, Ms. Stefina, for reading them out loud. I had a little lag on my end, so I appreciate you jumping in. But this is wonderful. I think we need to keep the energy. This day doesn't end this week. This is, we have a goal. We've got some way to go. I'm so incredibly hopeful with everyone today that we can make a difference with the HIV epidemic.
Thank you so much. And thank you all for being here. Again, there's so many great responses coming in, and you all are doing the work. So Southern HIV/AIDS Awareness Day, it is about raising awareness. It is about being intentional and having pardon me, conversations in our communities. It is about expanding our tent. And we would even love if your organizations raise some money, get some new volunteers, whatever it takes to get folks on board in your communities. We need folks to get to the polls. We need you to vote. Make sure for those of you with 501c3s that you are fully maximizing all the things you can do to build and empower the communities you serve and knowing what they can do when it comes to getting registered to vote and actually having an action plan for voting, because you can do that. And that is an important role that we play. We hope that you will continue to lift up Southern HIV/AIDS Awareness Day in your community. Join Southern AIDS Coalition back online at 1:30 Eastern as we have a conversation with Harold Phillips of NMAC about the upcoming USCHA and its focus on the South and Southern Joy. And we hope you will join us for programming happening over the coming days, and look to organizations in your community. There are great things happening all over the South. Great conversations being had, lots of celebrations, and the work continues. Thank you all for everything you do. Thank you to our partners at Gilead Sciences, the Gilead Compass Initiative, and everyone who made this time together today possible. And you'll get a follow-up email with the survey if you didn't get a chance to grab it out of the chat, as well as some additional resources to keep the conversation going. Thank you, everyone, and we hope you have a wonderful Tuesday. And don't forget, it is all about the power to the people. Thanks so much.
Thank you.
Beyond the red. Yeah, I'm living beyond the red. Yeah, I'm living beyond the red. I'm living beyond the red. I'm living beyond the red. Yeah, I'm living beyond